Good evening and welcome to our special panel with Daisy Hernandez and discussion of Chagas disease. This is a co-sponsored event, the UCLA Division of Infectious Diseases and the Program in Global Health at the David Geffen School of Medicine. I'm Judy Currier. I'm the chief of the Division of Infectious Diseases here and just really pleased to be here with everybody. The theme for WHO World Chagas Day 2023, which is tomorrow, is time to integrate Chagas disease into primary care. And this theme really highlights the fact that most people living with Chagas disease are unaware of their diagnosis, often until it's too late to have effective treatment. It's estimated about 6 to 7 million people are infected worldwide, and work by Dr. Meymandi estimates in LA County of about 45,000 people living with Chagas disease. Maybe we'll hear more newer updates on some of these numbers. So tonight's event is about a parasite and a disease, but it's really also about the power of storytelling and the importance of integrating stories about people impacted by diseases into how we practice medicine and how we teach medicine. I think if you read Daisy's book, you'll never forget about Chagas disease, and you'll never forget to think about ordering the test when you see a pregnant woman or you see someone with a different symptoms based on where they've come from in their past. So I think that's a pretty powerful thing to be able to accomplish through writing. So I'd like to introduce the person who came up with the idea for getting us all together tonight, and then she's going to introduce our panelists. So Claire Panosian Donovan, we call her Claire Panosian, but her official name is a physician who has a training in tropical medicine from the London School. She came to UCLA, to all of you, in the mid-'80s after being an undergraduate at Stanford and going to Northwestern for residency and doing Tufts ID training, which has always been known as a program with great tropical medicine training. And here at UCLA, she really launched the tropical medicine travel clinic and continued to work in low and middle income countries, writing, both doing research, producing reports, working as a journalist. And in the second part of her career, I won't say later because it's not done yet, of her career, got really involved in media and making documentaries about important diseases like hepatitis B, and more recently, the rat lungworm, which is a fascinating story all in and of itself. And so Claire wrote a really beautiful review of Daisy's book and had this idea of bringing Daisy here to talk to all of us and talking about this really important topic of Chagas disease. So Claire, I'm going to turn it over to you.
Thank you. And hello and welcome. And I'm so happy to see all of you in the audience. And I say hello to anyone who is connected by Zoom. Yes, I was very excited when I read Daisy's book. I have been a medical writer and journalist for the same amount of time I've been pretty much at UCLA when Marcus hired me in 1987. And I've written a lot of book reviews. I used to write for the LA Times. I wrote for Scientific American. I wrote for, my journal, the American Journal of Tropical Medicine Hygiene. When I saw Daisy's book, I thought this was a knockout. I had never seen quite that combination of memoir and cutting edge journalism. And I think it's a book that has already had a powerful impact and will continue to have a powerful impact. So if you haven't read it, I would really encourage you to do so. And I think it's very timely because, as Judy said, I think we are possibly at the beginning of a tipping point for Chagas disease. I really hope so. I really hope that the people in this audience leave today having a new concept of what we might do collectively or as individuals. But first of all, I want to say a little bit about Daisy. And then, of course, I have to say a lot about Sheba Meymandi, who is our local hero in Chagas disease. And I'm going to introduce them in order. But Daisy, there's many things I could tell you. She's had many honors for this book. It's really been nationally acclaimed. She's had many positive reviews. She's on Terry Gross, Fresh Air. The list goes on and on. But she was really born to write this book. So the background is that she grew up in a factory town, Union City, New Jersey. Her mother was from Colombia, and she had a number of aunties. I love that, auntie. And her father was from Cuba, and they weren't wealthy by any stretch. And one auntie from Colombia arrived in the US already having had a colostomy, and obviously was later diagnosed Chagas disease involving the gastrointestinal tract. Daisy was the medical translator for her aunt at age 6, something that would not happen today at Columbia Presbyterian, where her aunt was able to receive care from a very thoughtful surgeon. So she was lucky because she arrived in order to get treatment for the disease that had not yet been accurately diagnosed. So that clearly had an impact, although I don't think you understood the life cycle at that point. And she also knew, because she was very bright and she was the English speaker in her family, but she loved reading and writing, and she knew the power of writing. So I think you told me you knew you were going to be a writer before you finished elementary school. And then to kind of cut to the chase, she's been an investigative reporter. She's been at the New York Times. She has master's degrees in journalism and Latin American studies. And I think there was another one that you were going to tell me. We got cut off earlier when she was speaking, but she has quite a few credentials. She has written a wonderful first memoir, which I recommend, called A Cup of Water Under My Bed. And she's older than she looks. She's been the co-editor of a collection of feminist essays. She's written about women of color. She resonates with the community, the immigrant experience. And this is all powerfully, revealed in the book. At the same time, she describes a lot in a memoir style about her relationship with her aunt, which wasn't always smooth. At any rate, it's very exciting because it's just such an intense and powerful book. She has now recently been formally appointed to be at Northwestern, as I think Judy said, in the English department, teaching creative nonfiction, and in a new MFA program, which you told me is really very diverse. And so it's going to be an exciting experience. It's probably one of the best funded programs of its type. Okay, let me then move to my good friend Sheba, who is a cardiologist who was also someone who had an immigrant experience. She's a first-generation Iranian American, and if I can reveal, she has experience herself with chronic disease. She developed type 1 diabetes when she was 17. She's lived with chronic disease. She has a great compassion for people who are underserved by our healthcare system and who have to be hospitalized and don't know exactly where their lives are going. So she has been trained very, extensively as an interventional cardiologist. And when she came to all of you, I don't think Chagas was really on your mind, but she and Glenn Matheson from Infectious Diseases thought they would do some initial surveys of heart failure patients. And they detected Chagas antibodies. And over time, around the time that the blood test was approved for screening the blood supply in this country in 2007, she really jumped in and had the first center of excellence and remains the person, Center of Excellence for Chagas disease remains the person who has treated more Chagas patients than anyone else in the country. She has treated about 350 patients with drugs that are quite difficult. And she has been very aggressive about assessing patients with end stage, particularly cardiac disease, obviously, because that's her expertise, putting in defibrillators. So she brings a tremendous passion for this disease as well. And the two of them have intertwined already. For one thing, not just the immigrant experience, but Daisy spent time with Sheba when she was doing research for the book. Daisy's younger sister, Liliana, wrote a beautiful letter when Teodora died, and it made a contribution to the clinic, which Sheba has revealed to me really sustained a lot of her, during tough times. I mean, it's not as if Sheba had a simple time getting all of this great work done. So I'm hoping we're at the next stage. I thought that Daisy should start by reading a passage from the book and maybe explaining why she chose that passage. And then I'm just going to moderate and ask some questions, but I really don't want to keep talking too much. And we will definitely have Q&A from the audience. So start thinking about your questions. But now time for Daisy to, do you want to take this one? You got it. Read.
Okay.
First of all, what would you like to say? She's already spoken to the medical students. That was very different than this crowd.
Yeah, welcome everyone. Thank you for having me. Thank you for joining us. I know there's a lot going on in everyone's lives, so your time is really precious, and I really appreciate that you've made the time to spend with us. And thank you for hosting us and making all of this happen, Claire. There's a lot that goes on behind the scenes, as some of you might know. So it takes a lot to put together an event like this, and I really appreciate your work and the beautiful introduction. And I thought I would read so the book starts off with my own experience. And then, it took me a long time to figure out how to actually write this book, because as you said, there's memoir, there's also journalism, there's the stories of patients, stories of doctors. Dr. Meymandi is in the book. And then there was also the matter of having to introduce this parasitic disease to a general readership that doesn't necessarily know it and doesn't know the medicine or the science. I myself was new to it. I do not have any background in medicine or biology or anything. I really wish I had taken that biology course. So I really kind of sent myself to a little bit of boot camp when it comes to this. So I felt like I had to take my my reader as well through a bit of boot camp. So the book is organized in starting with the story of my family and how I came to this disease, then the story of doctors, and also some historical work around Charles Darwin and his contact with these insects in South America and the possibility of him having had Chagas disease. And then I move into the third part of the book, which is the story of patients. And I actually think that's where I want to read from. And I thought I had the page marked, but that's how it goes. I don't know. I had that wonderful. So I think this is the piece that I want to read from, which is a chapter about a patient named Carlos, who I could talk about for hours. One thing that I really just came to value and to appreciate is that the patients that I spoke to, so many of them, did not grow up knowing about Chagas disease. And so part of the reason that they were talking to me, willing to have long conversations over the span of several years in some cases, like with Carlos, is because they wanted to raise awareness. They wanted other folks to know about the disease and not necessarily have all the kind of questions that they had for so many years. And Carlos really opened up to me. So I'll just read like a page or two from his chapter. When I first saw Carlos in his Maryland apartment, he reminded me of my uncle. Carlos had ironed his polo shirt like my Theo used to do, and he answered my questions with care, inflecting his words with a certain deference towards me as the journalist, la escritora, speaking overall in measured, soft tones. He was the epitome of politeness, of being educado, as my tia Dora would have said. She would have liked him. We sat by the window in the one-bedroom apartment that Carlos shared with his 3 brothers. The living room had 3 twin beds arranged to form a wraparound sofa. The beds were communal. The brothers, who all worked in construction, slept wherever they happened to collapse on a given day, except for Carlos. He had the bed in the living room behind the television, the one next to the electrical outlet. Dr. Rachel Marcus had connected me with Carlos, and as I sat next to him by the window and turned on the recorder, I felt acutely aware that it was my first time meeting a person who had lost his heart to Chagas disease. The parasite had decimated his left ventricle, and so his heart could not get adequate blood to the rest of his body. He was in end-stage heart failure and needed a heart transplant. Of course, to me, Carlos did not look like a man who was dying. He had black hair and a generous smile. The only unusual feature was that he sat in his living room with a black messenger bag, its strap across his chest. He called the bag La Máquina, the machine, his temporary heart. The Maquina's official name is a left ventricular assist device, or LVAD, and it made it possible for Carlos to be alive. Inside the bag were batteries and a black box that looked like an external hard drive, a kind of mini computer whose wire entered the wall of his abdomen and connected to a pump near Carlos's heart. This pump did what his heart could no longer do. It sent blood continuously from his left ventricle to his aorta and to the rest of his body. To stay alive, Carlos had to have the LVAD connected to a power source at all times. Every 2.5 hours, he said he changed out the batteries. When he was not hooked up to the batteries, he connected the Maquina to an outlet, which was why he had the bed next to the outlet. At night, he plugged in. When doctors first said that he needed an LVAD, his brother Elias cried in the hospital room. "Don't worry," Carlos said to him. "How are you going to live with this machine?" his brother asked mournfully. Carlos had the same question, but he said, "I'm going to live a long time," because he did not want to see his brother so upset and because he did not want to die. The black machine in Carlos's hands made it possible for his heart to beat. And again, I thought of accordions, of the heart expanding and contracting, of a man forced to carry his heart in his hands. "Hace un ruido tremendo," Carlos told me about the LVAD, referring to how loudly it screeches if it loses power. It had happened one night while he was sleeping. He must have tossed and turned too much and the machine unplugged from the outlet. The neighbors upstairs heard it, he said. Another time, he told me, the Maquina howled and would not stop. His brothers had to rush him to the hospital. Without the machine, his own heart couldn't keep him alive for long. He didn't know what the problem was, and later I saw that his medical documents referred to a left ventricular assist device complication. I'll stop there. Thank you.
Well, the power of storytelling. So many places to start, but first of all, I have a couple of questions for Daisy, and then I'm going to follow up with similar kind of questions for Sheba about impact. When we spoke with the medical students, they didn't know anything about Chagas disease. So there was a lot of discussion about things that you all kind of know, but feel free to ask questions about that as well. This book has had, I would say, really tremendous national impact. It's now being translated into Italian. It needs to be translated into Spanish. And I'm thinking, frankly, about how it can be leveraged for maximal impact. Now, your publisher is Tin House, which is a very eminent but smaller publishing house. Have you had conversations about how this book is going to maybe encourage conversations? And there are so many items on the list of agenda for what Judy referred to, which is integrating Chagas disease into primary healthcare, screening. There's also a tremendous issue around having a network of providers that are ready to see the patients who get a letter in the mail from the Red Cross that says they're positive. That's another challenge. But just thinking out loud and brainstorming with this particular audience, what do you think about that? And what would you like to see happen?
I love the idea. Oh, can I be heard? No. Okay. We will share the microphone. I love the idea of brainstorming with all of you. So please stay after. Let's keep the conversation going. Yeah, my publisher has been incredible. Tin House is a small literary publisher. I was actually, frankly, surprised that they even gambled on this. When we approached publishers, we went to the big, this is how it works in publishing. You go to the big houses first, and then you work your way down. And the big publishers didn't want it because I wasn't a doctor. And so they were like, we don't, we only want stories from doctors. So hence, that is an invitation to all of you. They want your stories. They want your books. And so we worked our way, through this list, and they are really well known. They're very established literary press. So we were very excited, and they did a tremendous job in terms of getting coverage for the book. Ending up on Fresh Air with Terry Gross, that never happens. I can tell you this from all of my writer friends, that just never happens. And it let us reach an audience that would be interested, in these topics. But in terms of, I talked with them about getting into colleges, actually, because I think that even before medical school, getting to undergrads can have a huge impact in terms of the kind of career paths that they think about, frankly, later on. I don't think that Tin House is set up to do that kind of work, so that's where being with a smaller publisher does have some drawbacks. The fact that it hasn't been translated into Spanish is very just astonishing to me still. But I also know, because it's not my first book, that getting it translated into other languages is it's quite the effort. There's a lot of gatekeepers that are involved. But yeah, the publisher and I don't necessarily have the kind of infrastructure that you need to reach out to medical humanities programs. So it's fantastic to be here for that reason. But similar to what I said earlier today, I feel like it does actually come down to the political will of individuals. You heard about it, you saw it, you have your, context can invite us, but if only there was a Claire at every university across the country, it would be really fantastic. But it does require, I think, for us individually to do a lot more outreach than is sometimes humanly possible.
Well, the American Society of Tropical Medicine and Hygiene does have people on many campuses, and I think that this is going to be a goad. So that's on me, and I will see about that. And I just want to open this thought because it's a constituency that is kind of quiet and stoic and fearful, right? There are a lot of patients who are immigrants who have Chagas disease. In a way, they don't even want to open that letter that says that they tested positive. And so these are some special obstacles. Let me turn to Sheba now, because Sheba was very effective when she was doing outreach. This is on, right? Yeah. Okay. Yeah, good. Sheba, by the way, attended Catholic schools and has a wonderful nursing staff at all of you who were also great collaborators. So she was willing to, first of all, be very accommodating to patients, see them at night, see them on the weekends, but she did a tremendous number of health fairs, which is a way that a lot of people without insurance do get some medical care. And she collaborated through her assistants and her nurses with local parishes. And you were just very successful doing that. So the next step, in my view, we know that the public, all of you, was very supportive of the clinic and proud of it. But the larger LA County Health Department, there have been some different attitudes at times. You may or may not want to talk about that. Personally, I'd like to think about, we'd like to see this disease be reportable in California. It is reportable in LA County. It is not reportable in the state of California. It is reportable in Texas, by the way. And so we don't have as accurate of a head count as we'd like, but California could really lead the way. And what that might take is actually pressure on external agencies to become advocates. Kaiser, another healthcare system, perhaps the Catholic Church. So I'll leave it there and let Sheba discuss this further. Anything you want to say? Oh, you've got your own mic. Anything you want to say about the process of outreach and the next step of impact?
Good afternoon, good evening. Happy to be here. I have a lot of mixed feelings about my world of Chagas. It's been quite a journey. I've been pretty deeply involved, kind of solely involved, starting back in 2006. And I was very, very fortunate because I had a retired nurse who was as passionate as I was about the disease and was so passionate about bringing care to her community. She was of Mexican descent. She was a promotores with the parish nurses of Holy Cross. They had a wide network of churches that they worked with. And almost every week, every other week, they provided health clinics. So we kind of got incorporated into their system. I mean, even to the point where I call her Mama Jenny. She's my Mama Jenny. She's in her mid-80s now. She's still a powerhouse. You know, she would bring PVC piping with cloth, and we would bring echo machines and EKG machines, and we'd draw blood and do cholesterol. I mean, the whole spectrum. And we would see over 100 patients on the weekends. It was pretty amazing. It was really, really fun. And talk about gratification and gratitude, because when you give, when you do, that's when you feel the best about you. So I am a firm believer, getting back to what you were saying, you need champions to make a difference. Without champions, it doesn't matter what you do, you won't really make progress. Now, within different groups, there are many champions. Within this population, again, as you mentioned, they're poor. A lot of them are undocumented. They're not going to get out in front of the camera and say, we demand X, Y, and Z. They're going to say, thank you for whatever you've done or can do for us. And that's it. End of discussion. They're not going to push that envelope. I think we've gotten the most amount of attention from journalists. They're the ones, every 6 months, they would come around, can we have an interview? And that would spark things. Our administration, when we were doing this at Olive View, was very supportive. When that transitioned, we started having more difficulty in providing care, or actively providing care. We still provide care, but it's under the auspices of cardiology and not Chagas disease. It took 12 years to get this condition reportable in LA County. And the only reason that came to fruition was because I found a champion in the public health system, one woman. Oftentimes it takes one passionate individual pushing that envelope forward. The state public health couldn't find a champion. So my champions have been individuals like Mama Jenny and providers that have gotten very interested in Chagas. And we've now gone from, an entity of, 1 or 2 to a pretty significant network across the US. And we've now have centers in Florida, obviously LA, New York, the DC area. So that's been very rewarding. We've gotten the medications, both medications approved by the FDA, which was a huge undertaking. So again, a lot of progress. But then when it comes to getting it into the primary care system, if we could get the Kaisers of the world, that's where we'll see impact, because they are the model that sets the standard that every other organization kind of follows. And how do you go about doing that? I don't have the answers. I've kind of failed at that because I haven't made inroads. I found one infectious disease provider who used to see all the patients for Kaiser who had Chagas, who's subsequently retired. And I'm at a loss for words, because for me, this is the epitome of primary care and preventive medicine. And it's easily done. I'm a cardiologist. I'm not trained in infectious disease. I don't even like infectious disease. But, it's not difficult to do. Ideally, you want specialists dealing with the patients because the side effect profile of the medications are pretty significant. But all we need them to do is to get the testing going, right? And for example, at UCLA, how can you mandate that your primary care providers do screening for the Latin American immigrant population?
Let me jump in with an idea and have both of you comment. There's a wonderful phrase in your book. It's not entirely accurate, but it could be just tweaked. Every adult with Chagas disease is a child who was never treated. So we all know that congenital infection is a kind of a black box. You know, they have estimates of how many babies are born with it from mothers who carry it unknowing. Those are very treatable patients, both the pregnant woman and the baby. And that could be a very provocative slogan, billboard. I mean, maybe that's a way to start. Thoughts?
Well, I can't take credit for that phrase. It's actually an Argentinian doctor who really moved me when he said that. This was at a conference, the actually tropical medicine conference. And he said that, yeah, every adult is a child who didn't get diagnosed, didn't get treated, in part because a lot of times you're going to see those symptoms, 10, 20, 30 years later. And it really caught my attention in part because at that point, I had not thought about at what point my auntie herself had contracted this parasite. And then as I talked to more families and started to hear their stories, Janet, who I write about in the book, whose baby was born congenital case of Chagas, she remembers being a little girl and having the insects on her, waking up and having the welts from where she had been bitten. So it's very much something that children experience in South America and Central America and Mexico in certain rural parts, right, that are very poor. But as Sheba has talked about and talked about earlier today as well, if we can, so children respond really well to the medications that are available. And for girls who are going to grow up to be moms, right, that those medications can also cut off that transmission of the parasite. So again, to me, it feels like absolutely a key part of primary care. I'm actually not, so I'm a writer, but I'm not a marketing person. Marketing people are really valuable, but I agree with you that there are ways that I think that we could use, phrases like that or language to get attention, frankly, and to draw more attention and more support for it as well. Yeah.
There are many activities, even in the US, that are geared towards women and women's health and the pediatric population. The fact that the majority of you haven't heard about these is, again, very telling. Patricia Dorn has spent the last, I think, 5-10 years of her career pushing women's health and pediatrics. Honestly, until it affects your family, I've dealt with a lot of politicians also who, act interested but do nothing until someone they know tests positive. And that's when the calls come where they will be willing to do anything. And then once you do the confirmation and it's negative, they disappear. So it's been very, very frustrating. And again, the network is increased. A lot of people are focusing more attention on it. I think that's one thing that's really effective that I've seen. I don't watch much TV. I actually don't have TV. But when I do watch it, every other commercial is a pharmaceutical commercial, right? And when you're sitting in your office and patients come in and say, oh, I saw this commercial on X, Y, and Z. Would that work for me? That would be one angle. I know Bayer, who makes nifurtimox, does send out Chagas emails to some providers. Have you guys ever gotten these emails? I think they only send them to the providers who are on their list of Chagas provider networks. So they exclude the majority of the physicians in the US. But if we could get the distributors of the medications, at least, to put some of their funding, they got for the PRV for this medication, but the 2 medications, they got a lot of money for the PRVs, for the priority review voucher that then they turn around and sell to another company for millions of dollars to get an accelerated review of their new drug. It's quite a gimmick. They brought old drugs from the 50s and 60s and they got millions of dollars once it got approved. Take some of those millions and at least put advertisements out to the public, to the general public, bring awareness to people who may be at risk. You know, it could be a 20-second slot. I mean, in terms of how to reach the populations that are affected, put it in a telenovela. You know, how many American non-Spanish speaking people learn Spanish by watching these telenovelas, right? So there are a lot of little things that I think we can do to increase, to raise the bar, but it takes champions and it takes money.
I'm wondering if Judy would like to comment. She has a lot of experience with promoting.
Well, I was going to say one of the things we talked about this before the program started that could really refocus people is the intersection between climate change, you know, and temperature and distribution of the parasite in the United States in terms of where people might be at risk of getting infected. And I think that's not just, you know, people who are getting infected in other places. I think that when we start having more cases that were from people who never left here, and that I think is going to get people's attention more. And also the other thing I was thinking about was the screening of pregnant women, how we screen for so many things that are so in this particular population, so much less likely, and we don't routinely screen, as far as I know. The one experience we have in our division here for screening is in our heart transplant clinicians in ID. All of our heart transplant patients are screened and then are managed, but that's not really when you want to be finding out that that's why you have heart failure. But that is where there is some experience in treatment.
Right. But the reason they're screening also is so that the heart doesn't get rejected with reactivation of Chagas. So, you know, which comes first, the horse or the cart? I don't know. Carolina is an expert on migration and climate change and tropical diseases. Carolina Batista, she's a physician. She's got her master's in public health. She does health economy. She's quite knowledgeable, and she actually just got a paper published on climate change. Judy, Carolina, can you raise your hand? Maybe you can say.
Sorry, here you go.
I was shy. Yeah. Hi. No, thank you. I think, first of all, congratulations, Claire, for putting this together. I think it's so rewarding to see. I wish I had the opportunity to see such a panel when I was in medical school. And I'm Brazilian, so maybe my accent has already given you a hint, but I didn't have much opportunities to learn about Chagas in Brazil, even though the disease is very prevalent in the country and, was discovered and really documented by a Brazilian physician, Carlos Chagas. So it's a shame. And I say that, in an unfortunate fashion. And that's why I think I've dedicated a lot of my career into creating programs to exactly promote the acceptance, the uptake of Chagas diagnosis and treatment by communities. And I think the aspect of climate change and not only Chagas, but vector-borne diseases is such a big topic right now. And we're just discussing this over lunch with Daisy. The boundaries of those diseases are just going up to the global north. And I think this whole paradigm that used to be us and them for tropical diseases, it's just going to be diluted more and more. You know, you have cases now of dengue fever in Portugal, in the south of France, in Hawaii, and all of these diseases will be more and more endemic. So I think Chagas, you know, we've had, and I've shared that with Daisy also, you know, when there was Katrina in New Orleans a while ago, there were autochthonous cases of Chagas.
No question.
Right.
Daisy covers this very well in the book, and there's modeling that even, I think it might be a little bit generous, but the thought that there might be thousands of autochthonous cases in the United States. There's more surveillance now of the triatomine vectors in places like Florida. There's plenty of the parasite. The parasite is zoonotic. It lives in many animals, and they can even do studies and see what those bugs have, what kind of blood they've ingested, and it includes humans and many different animals. So there are studies that are supporting this, and I couldn't agree with you more. Yes, when it hits home, people begin to take notice. But I also feel that the mother-infant infection, it really, you know, this is something that we should be ashamed of, any of those infections slipping through the cracks when we know how to prevent the continuing propagation. I'm wondering now if we should open up for questions from you or the chat. I don't know, Judy, if you've got questions in the chat, but
I hadn't seen any.
okay.
I think one other thing maybe before that is, you know, we do have students and fellows and people earlier in their careers here who are thinking about what to do. And I remember just thinking of my own experience when I started out and HIV was starting, and I decided I wanted to work on HIV. And a lot of people said, oh, don't waste your time with that. You know, like that's not, you know, don't get sidetracked. That's not what you need to be doing. And I think, you know, I'd love to hear your perspective on that when you started wanting to work on this rare disease. You know, the fact that we don't support people who want to do something different with their career. I mean, you know, we really are trying in our infectious disease training program to be more broad-minded. It used to be, if you were going to be an infectious disease doctor, you went in, if you wanted to do research, you went in the lab and you figured out something, and that's what you did. And even doing clinical research was sort of frowned upon. But I think trying to chart your own path, maybe hear a little bit about that, even from a author's perspective, writing about something like this is a little different. I mean, I guess it's a memoir sort of, but do you want to both reflect on that? And then I'll look for questions here.
I think when I started from my division's perspective, again, cardiologist, so no one was really into infectious disease, but there was a lot of support because we dealt with the heart failure population of this disease, which is pretty devastating. So we had that foundation of support. We couldn't get any financial support to do any of the screening from NIH, CDC. I mean, we applied for grant after grant and to no end. So what we started to do is doing pharmaceutical studies, clinical trials, generated money, and those monies that we made went towards supporting all our Chagas activities, everything. So the county didn't pay for this, which is another reason it's so surprising that they've kind of nixed it, because really we paid for the majority of the activities. But it comes down to finding an area that you're really passionate about, where you feel like you can make a difference and have an impact. And if you have that goal and you have that drive, you will figure it out, guaranteed. And you will always find people who are in your corner that will help promote you. And I had my mama Jenny, and you know, that's really all I needed. And with that enthusiasm, it's infectious, right? People get on board, and you know, people, one person influences another, you turn into a group and then a crowd, and you know, you have an impact. So, you know, we were very fortunate.
this will be a quick one. Diversity, equity, inclusion. I mean, this is like the buzzword we've been hearing for the last 2 or 3 years, and not inappropriately, but this fits right in with that. Daisy.
Yeah, I was going to say that, my own experience is that, I think I mentioned earlier, like, I don't have a background in medicine or science. Like, I was not the person to write about this. The publishers were like, we don't want your book. You're not a doctor, blah, blah, blah. And I didn't let any of that stop me because I really, really believed in this, and that's been my experience, that when people believe in something, it will carry you past all the haters that you were talking about, and people will show up and open doors, right? Dr. Meymandi opened a door, spent time with me explaining, really early on, I felt like I was like in med school with Dr. Meymandi, and there were others that, really opened the doors. So that's been my experience, that, when you need to do something and really feel it in your heart, the rewards are just incredible, but it will also carry you through the inevitable rejections or, dissenters, et cetera. And then you also have to make sure that you create, I say always, a tribe, a community of comadres. Comadres is like a Spanish word for like your bestie, your best friend forever. It's important to have that tribe, whether they are in, your field or outside of your field. My comadres are like, some of my comadres are way outside my own area, but those are the people that I call on in those moments when the doubts are overwhelming, when I'm like, what am I doing? What was I thinking? They keep you going. And I feel like having those comadres, that Mama Jenny in your corner, is really, really essential, no matter what you end up doing. And I also think that there's something, I don't know, I guess we haven't spoken about this, but like, I feel like there's something so, for me, so gratifying about actually writing on a topic that no one else is talking about, that no one else is paying attention to, I feel like it could be really easy to be like, kind of discouraged, like, oh, I'm like in the corner screaming by myself or something, but that hasn't been my experience. I feel like, hey, I'm like, something important is happening over here and I need you to look at it, I need you to pay attention. I find that to actually be like, I don't know, encouraging and inspirational for me.
From the chat. And this is from Paula Granados, who also said local transmission is happening here. But for Sheba or others, what are your thoughts on rapid testing for federally qualified health centers, since there's not much funding or incentives for them to be able to test, especially thinking of OBGYNs?
I was showing you a email that I just received. A company called Currier had been working on this assay with a confirmatory test included, that just got FDA approval. It will be announced tomorrow. So they emailed to let me know first, or I'm sure a group of us. The issue with these smaller clinics for low income individuals, it would be great if they could get it on a compassionate use basis to use these tests, but they're not inexpensive. So that's the rate limiting factor. If they got government funding for testing like this, absolutely. I mean, we used to have the ones in our vicinity in San Fernando Valley do the testing, and then I would have volunteers and go pick the samples up to bring it to all of you to then send it to the CDC. But that is so labor intensive, and it comes down to money. I think that's a fabulous idea. Even when we were doing that, the volume that we were getting was pretty low. So again, it's having the champions at the facilities promoting this activity. Because I can tell you, if I were at that facility, they would be testing a lot more. So it boils down to having champions, people who are really, really vested in the disease and making a difference.
We have a brand new medical school in Pasadena. It is the Kaiser Medical School. Their mission is to do implementation research, for which Kaiser is well known. And it's long occurred to me that they might want to become involved in Chagas, and not now, but maybe some of us should think about really advocating for them to take a role. So Now let me make sure there must be some questions from some of you. Please.
I can take the microphone. Be the-
We have a
Roving
little
mic.
microphone right here.
Oh, you do? Okay, great. Even better. Thank you guys.
I have a very easy question. As a provider, who would you want screened? I mean, every single immigrant from Latin America, anyone who's has a parent who immigrated from Latin America, you know, what would you like to see?
It depends on your resources. If resources and your testing aren't very expensive and you can get it done readily, easily, I would test every Latin American immigrant that walks through my door. If I need to be more judicious, I would focus on female population, women in reproductive years, peds, and those, there in our studies, there were 3 characteristics that increased the prevalence of the disease: lower education, those who were knowledgeable about the disease, had heard of Chagas or knew of someone who had Chagas, and those who lived in poor conditions with adobe housing, mud walls, thatched roofs. So depending on your practice and your financial resources and your administrative support, that's how I would kind of tailor it.
People are asking if the talk is going to be posted, and one of our listeners is listening from Egypt. So we'll have to figure out where it can be posted that people could actually access it.
That's exciting. Yes, please speak up.
YouTube was a great idea. They said.
Hi, well, thank you so much for being here. This is such an incredible event. You know, your book really centers around the story of Theodora, and but throughout the narrative, you kind of introduce other family members who have suffered from other parasitic diseases, and there was one that kind of really stuck out where you weren't even aware that this family member had passed away, and it sounds like she passed away at a very young age, probably from another parasitic disease. And I think it's very common in families when young children do pass away, often from infectious diseases, especially coming from places like Latin America and lower middle income countries, that the inclination is to bury those stories, not talk about them. And I was struck by how for you and your sister, the response was kind of the opposite: to write about it, to make this story public, this story really at the intersection of medicine and human rights. And I wondered if this was kind of an opportunity for you to tell this story, but also kind of process some of that family trauma. So I was just wondering if you could speak about that.
Yeah, thank you. And yeah, that was actually one of my mother's sisters who died at a very young age, and who I never heard about until just one random day when an auntie mentioned her and told a little bit about her story. And yeah, you know, it's interesting because when I started writing about this, I actually didn't think that my auntie had just recently died from Chagas. I didn't think that I was processing anything. I just thought I need to learn more. And I didn't see a book like this out in the world. And I live by Toni Morrison's statement that if the book does not exist, then it's your job, your responsibility to write that book. So I live by that. So I was like, I need to find other families. I need to tell their stories. And in terms of like navigating through, actually, right up until the last moment, there was going to be no, I think maybe I was thinking of mentioning my auntie in a paragraph, you know, and it was actually my editor who said, would you be open to writing more of your family story? And I thought, who wants to read that actually, which is what my students always say. And I'm always telling them, we want your stories. That's the entry point into these larger issues. So I'm really thankful to that editor for suggesting that. But for me, I think that, you know, the project as a whole was, you know, in some ways it's a sense of personal restorative justice, because we didn't grow up knowing about this disease. We didn't have access to information. This is like pre-Google, right? And because of the kind of, you know, economic conditions that my family grew up in South America and then had here in the US, you know, my parents My dad has, you know, a third grade education. My mom has a little bit of high school. We don't sit around, you know, the table talking about infectious diseases, and tropical medicine was a new word for me, you know, when I started working on this project. So for me, it felt a little bit like, yeah, I need to rewrite my own family story. It's a sense of like personal justice, but it's also a very collective experience. You know, I am not the only one who has grown up in a family with kind of half fiction, half truths about infectious diseases, right? So I felt like, okay, I am one little seed that I am planting, and I am trusting that there are going to be many other Latina and, you know, other folks from other parts whose families are from other parts of the world. I trust them to like go and write their memoir and their book about the same subject. But it was actually only much later in terms of just kind of processing even like the grief around losing a family member to this disease. It was only much later, like that I was like, why am I even writing about my family story? Like about sort of losing my auntie. We had such a complicated relationship, and the grief is complicated. And I realized, oh yeah, we actually don't talk about those kind of complicated griefs. Like we understand grieving someone that we adored and loved deeply and kind of had a long relationship with, but we don't really talk about how do we grieve that like toxic family member relationship. And at one point when I was with a patient, actually with Carlos, which is I think part of why his experience is really close to my heart, I was interpreting I wasn't like interpreting medical stuff. It was just a small, like, you know, at the desk with his ID and whatever. And I just had that moment where I realized, oh my God, I have like recreated my family experience, but as a journalist, now I'm translating in this moment. So I realized, oh, this is so deep right now. But yeah, you know, we go on crazy journeys for any of you who decide to write a book, you will go on a crazy journey, no matter what you think you're doing with it. It will end up being an unexpected experience.
I think we are also hearing a good case for medical humanities in this conversation, which is something that is really gaining traction at UCLA, as well as other emerging infectious diseases in our own division. So I'm hopeful that this conversation will be inspiring to those of you who are physically here and others who have access to the conversation. Any other people would like to comment? Marcus, good.
So what we have here is a great neglected disease, of which there are others that mostly in low income, middle income countries. And those ads that you used to listen to that rarely, when you did watch TV, were for cancer drugs because you can make tons of money with a cancer drug. So these diseases tend not to get the support they need. So my question is, how would you contrast the perception by the public, government, foundations of Chagas with some of the other neglected diseases, TB, leprosy, so forth?
Well, I think TB, leprosy, the Novartis Foundation is very much into leprosy. TB, as we all know, gets a ton of attention, a ton of money, as does malaria. So I think you have neglected diseases, yes, but amongst those diseases, there's the neglected of the neglected diseases. And I think Chagas is the neglected of the neglected diseases. So, and I think that's been recognized at least for over the last 15 years that I've been involved. And you look at Gates, the Gates Foundation, they will not give you, if you're dealing with Chagas, they will not give you funding for anything except for possibly educational stuff. So it's not a sexy, neglected disease, even though it impacts hundreds of thousands of millions of people. And, you know, again, I think we know if you screen early, diagnose and treat, you have a huge impact. I always say it's the epitome of preventive medicine, and why we don't do it. I don't understand. And I get very frustrated. And this morning I said, it just pisses me off, but hasn't really, we haven't gotten there yet. So if we can get into the Kaisers of the world, anyone has any influence with getting that as part of their protocol, part of their panel. At all of you, we used to have it on the OBGYN panel for pregnancy. It was a checkoff.
Your question reminded me of early on in the project, I interviewed someone who did have money from Gates. And so when he was talking to me about Chagas, he was like, can you connect it with AIDS at all? And I was like, oh, wow, this is where we're at in the conversation is, having to connect it. But, I think it's actually a larger reckoning around public health in the US, because I think what I write about in the book is that this disease, essentially it's contained right now to the Latin American immigrant community. And so we don't have to look at it. We can look away, right? And I would say the same has happened with HIV. HIV is a huge crisis around Black men in the South, but we can look away from the South. Then when it pops up in, the Midwest, it gets all the national headlines. It was incredible to see that happen a number of years ago. So I think there's, we could use it, for those who work in public health, right, as a larger, entry point to a larger conversation around public health in the U.S.
Yeah. You want to say something about your next book, just in passing? She already has a new contract for the next book.
Always so dangerous to talk about the next book when you're just early in the relationship. But part of what I couldn't talk about in this book because I felt like it would be too overwhelming was the issue of citizenship and the kind of access that we have to healthcare, the ways that we make it contingent on citizenship. And so I started writing, there was a whole chapter and I was like, yes, this is going to be like a central part of this book. And then I realized that I was giving the reader a lot. So part of, huge decision that you make when you're writing nonfiction is it's not so much what to include, but what you need to exclude and put to the side. And so I realized that that was such a much larger conversation. So my next book is this, it's a consideration of, citizenship and specifically in the United States. And of course, I'm always writing about Latinx diaspora. So it has that particular angle, but there's a next part that chapter that was previously in here is now a chapter in the new book, which is, just the reality that depending on where you are in the United States, if you're undocumented, if you're a legal permanent resident, that can really determine the access that you have to healthcare now. And it's been interesting to look at just some of the, for example, kidney disease and talk about people who have had to step up and champion for undocumented folks to receive, care before they get to a critical stage. It's been really, really incredible to see that. It's, when it comes to marginalized communities and healthcare, it's basically, individuals and champions, that people that step up and do a lot, with very little.
I have just one other final thought about this in the future and a positive thing. So it looks like we're going to get another training grant in our division that's led by Otto Yang and Risa Hoffman and Karen Nielsen for emerging infectious diseases. But one of the problems is having people to train with who work on these things. And I think one angle for Chagas is understanding, there's so much about heart failure we don't understand. And it's as a pathogen that causes heart failure, there's a lot we could learn from HIV. We've learned a lot of things about basic biological systems that we didn't know that HIV taught us. And it seems like there's a lot that Chagas could teach us.
But I guess arrhythmias.
Right. But I guess my ask is that hopefully you'll still be around when we get that ID fellow who wants to work on Chagas, that we can reach out to you to connect to the network. Because I think that's often the issue is, who can I work with? Who's going to mentor me? Who's going to connect me? And so we have to think more broadly about how to make those connections so that people that are interested have a pathway.
Well, that seems like a very good closing note. We have a reception where we can continue conversing casually. I hope you'll stick around. And I think this has been a wonderful session. And I want to thank Daisy, Sheba, Judy, and all of you for coming. So Thank you very much. Let's do it again. Over and out.
Thank you so much. The nurse today said,